discussing all topics about the hip. Mr. Khalid? The first speaker will be our eminent Professor Raouf Al-Abbasi from the Military Academy. Professor Raouf will speak about conversion of internal fixation around the hip to total hip arthroplasty, which is a very important talk. Thank you so much, Professor Raouf, for being with us tonight.
At first, I would like to thank Professor Mohammed Al-Ashab for allowing me to participate in this outstanding meeting. My talk today will be on conversion of failed internal fixation around the hip to total hip replacement. Failure of fixation is largely accounted for by non-union, loss of fixation, hardware cut out, and avascular necrosis. Conversion to total hip replacement has poorer outcomes and associated with longer operative time, greater cost, and greater morbidity and mortality rate compared with the primary internal fixation with acute total hip replacement. The possible presence of occult deep infection should always be considered, and baseline complete blood count, ESR, CRP, and aspiration in overly suspicious cases should always be performed preoperatively. Many of the technical consideration of these procedures are similar to those encountered in the revision total hip replacement. Limb length discrepancy should be recorded preoperatively. Removal of the metalwork is a particular concern and may leave stress risers. Cortical defect in the femoral shaft must be bypassed by at least 2 cortical diameter to avoid periprosthetic fractures. I'm going to present some cases with failure of internal fixation. My first case is a basal fracture, which was fixed with DHS. And unfortunately, there is a breakthrough of the screw, as shown in the X-ray. And the plate, the DHS has been removed, taken off, and a total hip replacement was done, allowing early restoration of function, minimizing the pain, which was listed by the patient, and early return to work. The second case, still the same. This is an unstable pertrochanteric where the posteromedial cortex is defective, and this is not an indication for DHS. In these cases, I prefer to do whether a primary total hip replacement or to nail this fracture with a proximal femoral nail. And still the same, we have taken off the metal work and we have done total hip replacement with a captive cup because the abductors was not in a good condition. My third case was still an unstable fracture where still a DHS was done with sliding plate for fixation of the greater trochanter. The first X-ray were not bad, but a few months later, this was the picture with the CT. There is a cut through, which is very evident in this X-ray. And it was very cumbersome to take the metal work and to do, it is more difficult than a revision total hip replacement. So we did a total hip replacement with a captive cup and the Wagner cementless prosthesis. All is cementless. Case number 4. This 52 years old patient with fracture neck of the femur, transcervical fracture, which was fixed with a proximal femoral plate with non-union. So we took the decision to take off the metalwork and to do a total hip replacement to allow early restoration of function and back to work. Case number 5, still a proximal femoral plate done in a bad way with proximal migration of the femur and non-union of the fracture with about 4 to 5 centimeter shortening. The metal osteotomy was done and the metal work was removed and the total hip replacement was done still. A cementless total hip replacement with a captive cup and the long Wagner stem. And the greater trochanter was sutured to the prosthesis. Case number 6. This is an proximal femoral nail where the screw was moving up and perforates the sternum, the head and the sternum. It was very difficult to remove the proximal screw. So we did an osteotomy, a greater trochanteric osteotomy. We took off the nail and a total hip replacement was done. Still cementless total hip replacement. Case number 7. This was done 2 days ago with a broken nail and old fixation, old broken screws from a previous fixation before the PFM, where hip replacement was done, still the same, cementless total hip replacement with a long Wagner stem. Case number 8. This was a fracture of the femur with neglected fracture, basal fracture of the hip, of the femur, with non-union of the femur and this neglected fracture proximally. There was a history of infection, which was treated until we had 3 consecutive ESR and CRP negative. So we took the nail and the fracture was non-united. So put a plate, a locking plate, and we did a total hip replacement. I was planning to do to bypass the fracture, but it was very difficult because the fracture was not united at all. So there was an element of rotation. Case number 9. Still, this is a transcervical fracture, which was fixed with a nail. Unfortunately, the fracture was non-united. So we took the nail and the 4 locking screws, and we put a cementless total hip replacement. My last case is an old neglected fracture, transcervical fracture with avascular necrosis, which was where a total hip was done. Thank you very much.
Thank you so much, my dear professor, for presenting this unique collection of interesting cases. Thank you so much, Professor Raouf. We will delay the discussion till the end of the session. Now we will move to the second speaker, Professor Baha Farana. Professor Baha will speak about a deformed hip case. Professor Baha is a cornerstone in our every webinar. Thank you so much for supporting us.
Thank you, Ashab, and it is my pleasure to be there. I make an uploading to my case. Can Khalid?
Mr. Khalid, Professor Baha case is recorded, I think.
Bismillah ar-Rahman. Bismillah ar-Rahman. Bismillah ar-Rahman ar-Rahim. It is my pleasure to be in this international clinical meeting and appreciating for inviting me. Thank you for Professor Ashab for this organizing all these people. This is the most beautiful smile. And this was the first case is a female patient, 35 years old, known as MS for 5 years duration. The first attack was 5 years ago, and she was received Cylibintrol, which is a type of corticosteroid, with then used interferon with beta 1. Patient stopped her medical treatment. Finally, neurological consultant changing this to another drugs with Gilenya. Patient was complaining of 2 attacks per year, and the consultant asked because she's suffering from hip pain, was for MRI, and then was diagnosed as a vascular necrosis of the right hip. Patient advised to see the orthopedic surgeon, but she neglected to go for orthopedic consultation. 3 months ago, patient admitted to our hospital with right loin pain. During the hospital was fully prepared. Inspection, there is a fixed friction deformity affecting the hip and the knee for with a 20 degrees range of motion, painful limitation of range of motion. This is her lab, and this is her X-ray. There is a complete fusion of the hip with subluxation and dislocation. And on examination, there was a fixed deformity of the leg and the tenderness over the greater trochanter. She had no range of movement at the hip. This is her X-ray, and this is the knee X-ray, and this is the MRI with 3D CT scan also. Close up view, and this is the MRI. And the question is, what is the differential diagnosis and what other causes can be predisposing to this condition, and what are the management options for this patient? Multiple sclerosis is the main symptom, including fatigue, difficulty, vision problem with controlling the bladder, numbness, and other affecting the musculoskeletal disorder. She needs cooperation between dermatologist and orthopedic. So the aim of AROM is society gathering dermatologists and orthopedic for a better outcome. So what is your management for this patient? If you choose a technique, you choose its complication. If you choose a surgeon, you choose his complication rate. So every problem has a solution. So the problem here is technical and biological. Technical, you have used the hip through acetabulum location, very difficult migration of the head, severe acetabulum deficiency, bone quality, hip center identification, abductor muscle contraction. Biological relapse can be occur, soft tissue healing capacity, and infection, low immunity. Treatment has been in 2 aspects: immunomodulator and therapist to relieve the modify the symptom. So the treatment option at that time, total hip with ring and mesh, augmented, prefabricated or custom made. So the patient was prepared, and this is our patient on the table. You can see that after sleeping, there is a fixed flexion deformity of the hip. So we think out of the box. So the center of rotation, the core, has been identified. And so we did an osteotomy at the base of the neck. Then we remove the inferior part of the neck. The head is secured by screws to stabilize and help in fusion. Then preparing the acetabulum for the acetabulum component. And this is her post-operative X-ray. This is AP for this patient. So what is the post-operative management? It is a teamwork between rheumatologist and orthopedic and physiotherapist. This is a second case with a male, 48 years, RTA with head injury and was inability to walk. And this is his X-ray. It's wandering of the acetabulum was completely resolved of the head. This is a close-up view, and this is a 3D CT scan. The diagnosis at that time was difficult, but we reached that this may be a case of Charcot head. Difficulty in this case, think about the pathological anatomy, which are affecting the head. So the preoperative planning is evaluation of the preoperative lower limb deficiency or discrepancy, relocate the hip center and choose the appropriate implant and achieve primary stability. This is a post-operative case. We did assembly reinforcement ring using the Corpol acetabulum reinforcement device associated with allograft, cryopreserving allograft. This is a close-up view for this patient, and this is a pre-operative and post-operative. The third case is a female patient, 67 years, fall down, and she had operation 2 years ago, and this is her X-ray. There is a broken PHS with migration of the screws, and this is the lateral view, and this is AP. So what we can do, two options, either hemarthroplasty or total, and so why and when and what we can use. So this is an HOP trial in hemarthroplasty comparing with total hemarthroplasty for displaced femoral neck fracture. It is this study was at 2019. Conclusion: there is no difference in the outcome after treatment with either hemarthroplasty or total hemarthroplasty. So this is a patient we did for him hemarthroplasty with calcar replacement for the greater tumor. This is a follow-up of this patient. So always use what is available during the COVID. The last case is infected total hip after 3 revisions. 65 years old male, 4 operation for the hip, last 1 tumor prosthesis, and the patient came by this migrating of the femoral stem and migrating of the cup, and this is his position. The patient was taken to the OR and we found this, there is a penetrating cup which is coming from the wound, and this is a close-up views. You can see that the cup was penetrating and went through the skin and subcutaneous, and the cup was easily removed by the hand, and the cup came out with the screws, and you can see the infections, and this is infection, and we starting debridement, and we found that the bone loss up to 1/3 of the femur. So we prepare. This is after we remove the stem, and the stem have been used to lengthening the stem and incorporating in the prefabricated space. This is the spacer, and this is the stem pin, and we debridement the patient, and we inserted the spacers, and this is the position post-operative and follow-up for this patient. Patient was discharged from hospital with nice clean wound. For follow-up, he went to home and they met many visitors, separated coming home without taking any precautionary measurement. So he had COVID-19 for a few days and he passed away. At the end, thank you for you. The final thought is don't be shy with examination, with imaging, with follow-up, and if you cannot do a referral, with the referral can helping the patient. Thank you for your attention. Thank you.
Professor Karana, for this very interesting presentation, sir. Thank you so much, sir. Now we will move to the third speaker. Dr. Ayman Surial from UK will speak about periprosthetic fractures, the importance of preoperative preparation. Mr. Khalid,
مساء الخير على حضراتكم جميعا. Dear panelists, dear colleagues, Dr. Muhammad, it has been my pleasure to be asked to give a case presentation in this great meeting, where I have chosen one of the cases that I have managed earlier. My name is Ayman Surial. I'm a consultant trauma and orthopedic surgeon in the UK, lower limb arthroplasty specialist, and the case I chose to present was a periprosthetic hip fracture. This case I managed in Egypt in 2010 prior to coming to the UK, but I've kept the images, and I wanted to. It's always good to come back and revisit what we've done before to see whether there's any learning points. This is a 68 years old female, background of hypertension, type 2 diabetes, well controlled, good mobility until she had a neck of femur fracture on the right side about 1.5 years prior to this presentation. Had a cemented Thompson hemiarthroplasty with good function the first year, started to develop progressive groin pain until 8 weeks before she presented to me. There have been noted that she had a metal failure, as witnessed by this picture here of a failed metal failure of a Thompson prosthesis. She went back to the surgeon, the colleague who's done her index procedure, who have revised this and advised her to non-weight bear for 8 weeks. But then once she started walking, she felt she was unable to walk and felt something fail or give in her hip. She presented to me with this. Now, there is a lot of information to be gathered from this plain X-ray. I decided to have another look at this X-ray and top to bottom. First things, there was no prior radiographs available. The family said they were lost in the last hospital they were in. And as I said before, she was advised not to weight bear for the last 2 months. And it's not entirely clear what happened here, whether there was an extended trochanteric osteotomy or whether there have been a split of the proximal femur. It certainly looks as if there was an attempt at an ETO, but I'm not entirely sure about the fixation utilized here. There's definitely some element of acetabular wear, lower limb shortening, and the cementation. I could clearly see a line all the way down medially. This is otherwise a closed injury with intact distal neovascular function. Workup for infection didn't show any positive blood results, and indeed negative aspirate and negative intraoperative samples. Now, I think if there's anything to take away from this is how to avoid the situation. Revision total hip replacement is a demanding surgery. It requires experience and resources. Anticipation of difficulty in removing cement and cement extraction and stem extraction is very important. Adjuvant needs to be considered for extracting the stem and the cement, extended trochanteric osteotomy, bone window, use of ultrasound assistance. You just need to make sure that you have what it takes to go through this procedure. Backup plan for internal fixation in the event of a periprosthetic fracture, LCP plate or NCB plating system that needs to be there just in case. And if you're doing a bone window or an ETO, you can always consider utilizing a longer stem to bypass the area where you've done your osteotomy. Consider the need for bone grafting as well. That's rather important. Now, looking at this particular injury, I've looked long and hard trying to go forward. What is my Vancouver classification? There's 2 classifications, then the Vancouver, and now there's the unified system. Vancouver is still a very good classification system. I still use it. There's a fracture in relation to the stem tip, and the femur is split proximally, as witnessed by the circularized wires. Is this a stable prosthesis? Is it a B1 versus a B2? I had 2 options, either to get further cross-sectional imaging like a CT scan, or go in, because she needed an operation anyway, with intraoperative assessment. The intraoperative findings was no evidence of infection. Microbiology samples were negative. I've taken multiple samples. The stem was loose. the femoral split, or ETO, have not yet healed, and there was limited cement interdigitation. Therefore, I've made the decision to go ahead with the revision. And as there was evidence of acetabular wear, then the revision was a total hip replacement. There was some degree of devitalization of the bone behind the small plate, which is by far not a plate that can be used to stabilize a periprosthetic fracture, and I'm not entirely sure what would be its role in an ETO as well. So the procedure was revision using the Reef revision THR system. It was I used the lateral approach. I used to do all my hips through a lateral approach at that stage of my career. And I've used the lateral approach, which was the same approach as the hemiarthroplasty. The abductor mechanism was largely intact, and I've used a cemented acetabular component and uncemented long stem distally locked femoral component extensively coated. I've used some iliac bone graft laterally, and I chose, because that segment was, there was a segment that was completely devitalized by the previous patient, the new fracture. That was excised, and I chose some degree of overlap medially, and I've grafted the void laterally. Patient done very well, and I continued to follow her up to 2 years. She sent me her x-rays despite me being in the UK. There was no concerns about postoperative infection. She could weight bear normally with good mobility, good abductor function. She had a negative Trendelenburg gait and a negative Trendelenburg test. No hip pain, full radiological union medially with a small area of cortical deficiency laterally, but it wasn't symptomatic enough to warrant any further investigation. I was quite happy with her progress and discharged. I mean, there was no further follow-up after this. Thank you very much. I'm happy to take your questions. Thank you.
Friend, Dr. Ayman Suryal from UK for this fantastic presentation, sir. Thank you so much. We will have another two presentations, and then we will start a discussion. The next presentation will be done by my dear friend, Professor Wael Samir from Ain Shams University, Egypt. Professor Wael will speak about two-stage hip arthroplasty for septic hip arthroplasty.
Hi everyone, it is my honor to share this marvelous meeting, the monthly clinical meeting of the Egyptian Orthopedic Association, with the very active orthopedic department of Banha Faculty of Medicine, and under the leading of very active orthopedic professor, Dr. Mohammed Al-Ashar. Thank you for your invitation. I will present this short presentation about two-stage revision septic hip arthroplasty. Actually, this patient referred to us from Africa and complaining of long history of right hip pain. It is 31 years old male with previous hip surgery. Mostly it is debridement of previous hip due to recurrent abscess formation and persistent sinus discharging from pus. But actually, when referred to us, there is no active sinus discharging pus. As you see from the available X-ray, there is a complete distraction of the hip with wandering of the acetabulum, with bone deficiency in the superior part, and protrusion of the head inside the acetabulum, with complete distraction of the head, mostly due to intra-articular inflammatory process and mostly due to infection because the history of recurrent draining of pus, which is one of the major criteria of definition of septic arthritis, and confirmed by high inflammatory process with the CRP 160 with the ECR 94. So the preliminary diagnosis was a little bit easy. It is a chronic septic arthritis hip without draining sinus now. So our decision was two-stage hip arthroplasty because this patient is young and active, and the first stage will go inside and removal the head and the debridement of the acetabulum and removal of all the membrane inside and take tissue culture for histopathology. We usually take around 4 to 6 samples from inside the joint. And this is the intraoperative photos, complete pronation of the head and complete destruction of the articular surface. We remove the head, remove all the debris from the inside the acetabulum, and remove all the membrane and the biofilm. And I think one of the major success for such surgery is the aggressive debridement in the first stage. And within insertion, one of the pre-made prosthesis, cemento prosthesis, as a hip spacer loaded with antibiotic bone cement. And unfortunately, post-operative, all the cultures are negative for aerobic and anaerobic. And also we asked for this monoarticular hip arthritis, we should exclude the TB, and was also negative for the acid-fast bacilli. And we follow the patient by a serial CRP, and this is a serial CRP from 5 days post-operative. We declined the CRP from 196 to only 96, and 10 days was 24. For 1 month post-operative with 19 and 6 weeks is still 21. So the CRP declined, but the trend of the CRP not decline more and make a plateau at 20. It is about 3 to 4 fold of the normal CRP. So we are not so happy of this trend of the CRP, and to make sure that we are eradicate or control the infection in the first stage, we ask for an MRI over the hip spacer. And we found very interestingly a collection inside the pelvis underneath the iliacus on the medial side of the hip, and very clear here to be inside medial to the hip joints. And this is the available X-ray and MRI, but no changes inside the acetabulum or around the prosthesis in the femoral side. So we decided to go again to revise the debridement stage and to revision the first debridement stage and postpone to go for the definite hip surgery. And we add another approach, which is iliac part of the ilioinguinal approach with direct access to the collection on the medial side of the iliac bone. We drain all the collection, but we retained the prosthesis, the spacer, the cement prosthesis with antibiotics, because when we go inside the hip itself, the fluid is still creel fluids and negative for the examination intraoperative for the leukocyte esterase enzyme, but positive one for the pelvic collection. So we decided to keep the prosthesis itself to maintain the soft tissue structures and to avoid migration of the proximal femur and increase the shortening of this patient and complicate the further surgery. But we drain the pelvic collection. And follow up the patient, there is dramatic improvement post-operative. 2 weeks post-operative, the second debridement was 18. The 3 weeks post-operative was 6, 7, 3, 6. So maintained in the normal level till 9 weeks post-operative. The last 3 weeks were without using of antibiotics, what is called the antibiotic holiday, before the third stage, which is definitely will be definite total hip replacement. And we go to remove the prosthesis and go for totally cementless total hip replacement, and was ready by all means of reconstruction of the pelvic deficiency as tantalum augment for the superior deficiency. But we can, actually we succeed to achieve a very good breast fit by a large acetabular component with equatorial fixation between the anterior and the posterior walls without need for any acetabular reconstruction in the superior or the medial part. And this is about 5 5 weeks post-operative. And of course, we follow this patient again with a CRP and completely normal all through the follow-up stages. This is the 8 weeks, 14 weeks, 4, 12 about 5, and 14 weeks post-operative is about 2. So we succeeded to control or eradicate the infection in this case, and this is the last follow-up 1 year post-operative with osseointegration about the proximal stem and about the acetabular component without any change in the orientation of the component. So our take-home message here is that even in the end-stage septic arthritis, you should go for the MRI. It is what better to do MRI before going for the first stage. May we find this collection in the pelvic and deal with in the first surgery. As you see, CRP is very sensitive tool to detect any recurrence of the infection because of inadequacy of the debridement or presence of extra-articular collection. Non-normalization of the CRP or writhing, any change in the attitude of the CRP is an alert or indication of something wrong here for redeployment or revision of the first stage. So, and again, adequacy of the debridement is a key success of the hip arthroplasty after septic arthritis. Thank you for kind attention and waiting for the discussion later on. Thank you.
So much, Professor Wael Samir and Shamsi University, for this very interesting talk. Thank you so much, sir. Now we will move to the final speaker, Dr. Ibrahim Kamar from Sligo University Hospital, Ireland. Dr. Ibrahim will speak about hip peritrochanteric fracture.
Thank you, Professor Asha, for this invitation. I'm happy to be with you today. So the screen is with you now?
Yes, sir.
Okay, so today this is a light presentation about the hip peritrochanteric fracture. I'll talk today about one of the uncommon complications for a common procedure. We're doing this every day. My name is Ibrahim Kamar. I'm working in Sligo University Hospital in Ireland. Sligo is a nice small town in the the west-north of Ireland on the Atlantic Ocean. So today, our case is a 66 years old female. She has a post-medical history of AFib, atrial fibrillation on anticoagulation, and she has also hypertension. She had a mechanical fall at home from standing height, brought in by ambulance to our ED with right hip pain, shortening, unable to weight bear. Neurovascular was intact on examination, no other injuries. She was seen in and stabilized by the ED team, nerve block done for pain control, and X-rays. As we see now, she has she had intertrochanteric fracture of the right proximal femur with Evans classification grade 4 with displacement of the lesser troch. What's next? So the patient admitted to our hospital with fast tracked as per national hip guidelines in Ireland. The operation planned to be done in 48 hours post-injury after discussion with the anesthesia team because of the anticoagulation. Cephalomedullary nailing decided. We used in this case short gamma nail, gamma 3, uneventful procedure. Even there is some sort of malreduction in the X-ray as we see, but the patient discharged to step down facility for rehab on post-operative day 3 without any problems. So what the problem happened 2 months later, the patient attended to ED with increasing right thigh pain, swelling, and decreased mobility, admitted under medical team as suspected proximal DVT. They suspect maybe some sort of iliofemoral DVT. So they go for ultrasound Doppler, showed large right profunda femoris artery pseudoaneurysm. Then they go for CT angiogram, they confirmed the diagnosis and showed 9 by 6 by 7 centimeter pseudoaneurysm arising from the right posterolateral aspect of the profunda femoris artery with a large surrounding hematoma. And this is a 3D image of the CT. Then we contacted the interventional radiology to take their opinion about the next step for management. So they go for embolization, deploying multiple coils, 5 to 12 millimeter in length, The patient's symptoms improved over the about 4 days after post intervention, and the patient was doing well in the follow-up appointments in our clinic for about 6 weeks post this procedure. So our discussion regarding this uncommon complication, with all of us doing the cephalomodulary annealing like as a daily practice. So the hip fracture are common in elderly population. The lifetime risk of hip fracture is about 18% in women and 6% in men, according to Cooper et al. In 1992. The risk factors can be grouped as decreasing bone mineral density or osteoporosis, increasing falls risk. They are especially common among the elderly and of increasing global concern due to the aging population. Vascular injury as a complication after hip fracture repair is a rare complication, with reports ranging from 0.05 to 0.49% as per Zhang et al. In 2018. Vascular injury, as we mentioned, it is a rare complication, can be acute or chronic, resulting in a massive intraoperative bleeding or formation of subacute hematoma, leading to an arterial pseudoaneurysm. In orthopedics, pseudoaneurysm can be caused by direct injury from fracture fragment itself, dislocation, infection, iatrogenic causes including surgery. Arterial perforation results in hematoma formation outside the arterial wall, followed by recanalization. Consequently, the pseudoaneurysm sac remains connected to the artery by its neck. Risk factor for pseudoaneurysm formation: age over than 60, female lady, diabetes, hypertension, and arteriosclerosis, as per Kinoshita in 2018. The time between fracture and clinical manifestation varies and depends on the mechanism of arterial injury. There is a report ranging from 3 days up to 14 years. So pseudoaneurysm may be caused, as we mentioned before, injury by bone fragment and by over drilling, or the malposition of retractors during fixation if you go for OB reduction. About 80% of vascular complications after hip fracture involving the deep femoral artery, or what we know profound femoral artery. Delayed injury may be due to chronic erosions of the arterial wall by protruding screws or bony fragment migration. Management of this complication depends on a patient comorbidities and pseudoaneurysm location and size. So if we have asymptomatic pseudoaneurysm less than 3 centimeters in diameter, may be monitored in close follow-up for spontaneous resolution, as per Valley in 2018. For the large symptomatic pseudoaneurysm larger than 3 centimeters in diameter, options include open or endovascular repair, embolization, or percutaneous thrombin injections. And the majority of patients with hip fractures are elderly and post-surgical candidates. Interventional procedures may be preferred to avoid general anesthesia and the morbidity associated with major operations. So this is a light presentation, and thank you for invitation, Professor Ashab, and thank you.
Thank you so much, Dr. Ibrahim Kamar from Ireland. Thank you so much for being with us, my dear friend. Thank you so much, sir.
Thank you.
We have 10 minutes for discussion. Our dear panelists, if you have any questions to our eminent speakers, please do.
I have question, Professor Ashab, to Professor Abbasi regarding the case number 8. Why you not going for modular stem from start for this case, Professor Abbasi?
Can you remind me about this?
I know. I think this is the case with the because there is a lot of cases with broken DHS. So one of them, broken DHS, you bought a
DHS was the first 3 cases.
You know, there is number 8. I think there is you bought a hip replacement with the plate and screw. The case with non-union mid-shaft femur with neglected proximal femoral fracture. You know, so if you go for modular stem from start, why you prefer to go for this?
To do it, I was preparing everything along Wagner stem, but on removing the nail, the fracture was ununited
completely.
And any manipulation will make rotation. If you put the long nail, the long stem. So I went to fixation with a locked plate, a zipper plate, which is very strong, and to do a normal or
primary hip replacement.
But I was planning to put along a Wagner stem and to bypass this fracture by 2 diameters.
Thank you, sir.
You're welcome.
And Dr. Kamara,
Yes, boss.
this is Dr. Baha Korna from, we have a similar complication, but it is by the K wire of the DHS. It went through the femoral.
Yeah.
The resident went anterior, then go to the femoral, and then pull out down, and then the femoral artery is completely
injured.
Yes, cut down. And they proceeding for the operation, and they put the DHS after that, and they don't have any idea about the bleeding, and the patient went to the ward, and after that he developed a severe swelling of the leg, of the thigh and the leg, and discovered late, and after that he passed away.
Oh, because of this bleeding.
Yeah. This is also recorded in one of our hospitals.
It's a serious complication sometimes.
Yeah.
دكتور اشهب ازيك؟
دكتور عادل اتفضل يا فندم.
عايز يعني احيي المجموعه اللي موجوده. طبعا انا يعني كنت موجود من الاول وخرجت شويه. بحيي زمايلي وحبايبي. انا شايف الدكتور محمود شهاب والدكتور محمد الشافعي والدكتور وائل سمير، وحضرت انا الحلقه بتاع الدكتور وائل والدكتور ابراهيم قمر. انا سعيد جدا وفخور جدا بالمستوى، وفخور جدا بطول الكلينيكال ميتنج اللي ممتده بقى لها داخله على 12 ساعه دلوقتي يعني. فاحنا
لسه قاعد يا فندم سعادتك.
هندخل يعني الانسايكلوبيديا، او تبقى حاجه من الحاجات الريكوردد يعني من موسوعات طول الفتره.
بس احنا محتاجين دي في تي بروفيلاكس بروفيسور عادل.
نعم،
محتاجين دي في تي بروفيلاكسس عشان ال 12 ساعه دول.
والله طبعا، ما انت لازم تقوم كل شويه يا ابراهيم عشان خاطر ما يحصلش يعني انت على الكرسي تتقلب على الكرسي
عشان الالسرز.
مشكله. بس عايز اقول لحضرتك على حاجه عشان علق الدكتور بهاء. It's a very rare complication pseudo aneurysm. الحاله اللي حضرتك شرحتها دي بعد شهرين من العمليه she developed hip pain وسويلنج. فهي غالبا كانت حاجه انترا اوبراتيف بسيطه حصلت، وحصل معاها الجرادوال فورميشن اوف ذا arterial aneurysm اللي اتعمل ده.
I agree with you, Professor Adel, especially because the patient is on anticoagulation. She is taking apixaban, so this is also some of the risk factor also.
اما حاله الدكتور وائل سمير بقى كانت عجبتني جدا طبعا. يعني الفولو اب بتاع السيبتيك ارترايتس اوف ذا هيب دي يعني مشكله من المشاكل العويصه اللي مالهاش حل. يعني انا سعيد جدا، وكل سنه وحضراتكم طيبين.
طيب ان شاء الله. بارك فيك.
ازيك يا دكتور عادل؟ وحشنا.
ازيك، اخبارك ايه؟ اصل انا شايف الصوره معناها ان انت ممكن تبقى موجود وممكن مش موجود. ومحمد صبحي
لا موجود، بس حاطط عشان انا عشان كده بسمي الاجتماع ده كلينيكال انترناشونال ميتنج. كلينيكال انترناشونال ميتنج، مش هيبقى ناشونال.
تمام. تمام.
ازيك يا دكتور عادل بيه؟ ازي حضرتك؟
ايه اخبارك؟ كل سنه وانتم طيبين، وحشنا جدا جدا
والله. بالصحه والسلامه بيه.
ان شاء الله. اتفضل يا
السلام عليكم. اتفضل يا استاذ. اتفضل يا استاذ.
دكتور اشهب.
دكتور محمد بيه شافعي، اني كومنت؟
انا عايز ارحب بالموجودين واهنيك. كونجراتيوليشن، حاجه الحقيقه اكسترا اوردينري، حاجه فيرست تايم الكوميونيكيشن والاورجنايزيشن بهذا الشكل. يعني احنا ما عدناش الوقت يمكن في 5 دقائق لحد بعد 12 ساعه. عايز اسال بس استاذ الدكتور وائل سمير على الحاله الجميله اللي قدمها. in your experience and in readings تفتكر في كولكشنز بتبقى كومن فين؟ يعني اكسترا انترا بيلفيك، اكسترا بيلفيك في الالياكس انت قلت مع السوس، ورا في الادكتور كومبارتمنت، كومنلي فين اذا كان يعني عملت سيرش؟
لا هو كومن يعني كذا حاجه كان ناشر برضو، اللي هو الحكايه الانترا بيلفيك كولكشن، واحيانا يبقى مع الساي كولكشن. يعني احيانا يبقى جوه الثاي ناحيه الفيمر، واحيانا يبقى انترا بيلفيك كولكشن. انا بس المسج اللي اقولها ان ساعات لما يبقى الدايجنوزس بالنسبه لك سو كلير قوي، فانت ممكن ما تكملش بقيه الانفستيجيشن. انا الكلير مسج بتاعتي ان برغم انها كرونيك والعيان الانفكشن سيتلد وما فيش ساينس حاليا، فانت بتفتكر ان هي الامور سيتلد وما بتحتاجش MRI وانا داخل اعمل الكلام ده. فانا المسج بتاعتي لا، لازم برضو تكلاريفاي كل حاجه وتعمل MRI حتى في الكرونيك سيبتك سيتلد كونديشن، لان ممكن تفاجئ بكولكشن ايرثوير انت ما وصلتش ليه، سواء بقى يعني في ناحيه الفيمر سايد، الثاي سايد، على الميديال سايد بتاع الثاي، او انترا بلفيك ما شفتوش، يبقى انت هتمس وبالتالي العيان مش هيحصل له كومبليت ريكفري برغم ان انت عامل انترا ارتيكولار ديبرايمنت كويس.
ده كده احنا هنعمل MRI ونبص سكروتلي على حتت كمان معينه، يعني every part من البلفس والساي must be scrutinized.
يعني around the septic area ان في اي كونكشن ولا لا.
انا احب برضو ان انا ازود حاجه. كلام دكتور وائل طبعا سليم 100%، ودكتور محمد شافعي طبعا. احنا كان احنا كاوتو بلس يونت عندنا يعني اولموست كل شهر في حاله بتعملها ريفيجن فور انفكشن، وساعات الانفكشن كمان مش شرط ان هو يكون موجود حوالين الهيب، سواء في الانترابلفيك او اكسترا بلفيك ميتاستاتيك انفكشن. احنا عندنا كذا حاله نتيجه ترانزيانت بكتيريميا كان عندهم ديسكايتس. ساعات ان احنا we have to explore other metastatic infection كمان.
تمام.
دكتور محمد السلام عليكم.
بروفيسور وائل، any rule for CT guided aspiration for this collection؟
والله انا كان في رول بس انا ما حبيت ان انا ابقى definite radical debridement علشان الفيوتشر ارثروبلاستي اللي انا هعمله، لان مع CT guided aspiration الانسيدنس اوف ريكارنس هيبقى اعلى بكتير من الاوبن. وده كانت فاتحه بمجرد بس كانك بتعمل بون جرافت ودخلت دايركت تحت الالياكس، فقدرت اوصل للكولكشن كويس واعمل له اسبيريشن، وحطيت انتي بايوتيك برضه لودد من الحاجات اللي هي الابزوربابل ماتيريال.
ثانك يو.
السلام عليكم.
عليكم السلام ورحمه الله وبركاته.
دكتور محمد ازيك؟ بيزيد حضرتك. انا متشكر يا باشا على الميتنج الجميل جدا بصراحه. يعني هو في سؤال بس دكتور ايمن ودكتور وائل سمير بالنسبه للانفكشن. واحنا يعني هو السي ار بي انف ان هو يعني نعرف منه في انفكشن، ولا ممكن مثلا البيت سكان او خصوصا في الارثروبلاستي؟ يعني هو ده سؤال بصراحه ملح جدا عليا، عايز اساله يعني انا بثق في السي ار بي بس يعني، ولا ممكن زي طبعا كلينيكال سنس يعني والاكس رايز طبعا؟
هو انت عندك ميجور كرايتيريا وماينور كرايتيريا. الميجور كرايتيريا ان انت لو عندك ساينس او تو اسبيريشن طلعت منهم ذا سيم ديفينيت اورجانيزم، تو ايدنتيكال كلتشر، يبقى ده از ديفينيت انفكشن بيريبروستاتيك انفكشن. او عندك ثلاثه من الماينور كرايتيريا اللي هو السي ار بي والاي اس ار والليكوسيتيك ستريز انزيم، ودي زي الشرايط اللي انا وضحتها في البرزنتيشن، دي حاجه بسيطه جدا زي بتاعت الاسيتون بالظبط، وفيري سنسيتيف بسنسيتيفيتي حوالي 95%، واتس فيري تشيب. او الالفا ديفازين اللي هو موجود دلوقتي، او الانترا، او وان كلتشر بوزيتيف، يعني واحده بس مزرعه هي اللي بوزيتيف وطلعت لك مزرعه ثانيه، او لما تعمل الاسبيريشن تشوف التوتال ليكوسيتيك كاونت بتاعتها قد ايه، اكتر من 10,000 في الاكيوت واكتر من 3000، ونسبه البوليمورف نيوكلير ليكوسايتس بتبقى اعلى من 80% من التوتال ليكوسيتيك في الاسبيريشن. فانت لو عندك ثلاثه من الماينور كرايتيريا او واحده من الميجور كرايتيريا، ده الدايجنوز. فما بيبقاش في رول قوي للراديولوجي السي تي او حتى ايفن الMRI. الMRI بلوكاليزيشن للمشكله فين، انما مش فور دايجنوزس اوف ذا انفكشن.
أنا طبعا بأكد على كلام دكتور وائل واتفق معاه تماما. السي ار بي مهم جدا كجايد ليك في الفولو اب، يعني زي الحالة اللي عرضها دكتور وائل، هو عارض تحديدا حاطط السي ار بي سيكونشال. أول ما أنت بتلاقي السي ار بي بتاعك بينزل وبعدين بيوصل للبلاتو، أو إن هو ما بيتحسنش أو بيزيد تاني، دي نقطة مهمة إن أنت تقف وتفكر إيه السبب. لازم في سبب، مفيش حاجه اسمها يعني لازم ان انت تتاكد، ولازم قبل ما تعمل السكند ستيج بتاعتك تكون خدت كل البريكوشنز ونورماليزد الانفستيجيشنز بتاعتك قبل ما تحط